This lecture will look at restrictive disorders of the lower respiratory system. Restrictive lung disease is a decrease in the total volume of air that the lungs are able to hold. So it doesn't have anything to do with getting air in or out of the lungs, but it's about the total volume of air in the lungs. Often, this is due to a decrease in the elasticity of the lungs themselves, or can be caused by a problem related to expansion of the chest wall during inflation. Types of restrictive pulmonary disorders are atelectasis. This could also be an obstructive disorder, but we'll consider it restrictive for the purposes of this discussion. Pleurisy, pleural effusion, empyema, which we discussed under infectious disorders, sarcoidosis, and pulmonary fibrosis. The previous slide talked about pulmonary disorders that are restrictive. Sometimes disorders of the central nervous system or the neuromuscular system can cause a restrictive lung disorders. These are non-pulmonary causes, or sometimes called extrapulmonary causes. Things like myasthenia gravis, obesity, and arthritis are examples of this. A kyphosis of the spine or a severe scoliosis may hamper lung expansion. So the neuromuscular and skeletal disorders hamper lung expansion, but the lung tissue in these disorders remains normal. So of all of the things I just mentioned, atelectasis is probably the thing that you're the most familiar with. It's an incomplete expansion or a collapse of the alveoli. Areas of lungs which are not well ventilated become plugged with mucus, and this prevents inflation of the alveoli, and then they collapse. It's common in post-op patients or patients who hypoventilate. It may also occur from compression of the lungs from the outside, such as with a tumor. A decrease in surfactant can happen, as happens in ARDS, or a bronchial obstruction from secretions or a tumor. Breath sounds are diminished when the airways collapse, and oxygen saturation will decrease because no gas exchange takes place in a collapsed alveolus. The treatment consists of expelling the secretions by coughing. Deep breathing and the use of an incentive spirometer will help keep the alveoli open and functional. And if you do the deep breathing exercises before the cough, you will get the secretions up more efficiently. The focus of nursing care in atelectasis is prevention. This is an illustration of a normal lung versus atelectasis. You'll see that there's a bronchial obstruction here, and all those normal little alveolar sacs are totally collapsed, and therefore no air is getting in there and no gas exchange is taking place. So you recall you have pleural membranes around your lungs. You have one that adheres to the outside of the lung tissue, and then one that is like a sac that the lung tissue is enclosed in. And between those membranes, you have pleural fluid. Pleurisy is an inflammation of the pleura. If the pleural membranes are inflamed, they don't slide as easily and they kind of catch on each other. There's a friction, and this produces a characteristic sharp pain with inflammation and also produces a pleural friction rub. Times when you may get pleurisy include TB, pneumonia, neoplasm, which is lung cancer, and a pulmonary infarction, which is when you have the death of a lung tissue. Most frequently, you'll see this during pneumonia. Again, it's a sharp, abrupt pain and is most evident on expiration. And because it's so painful to breathe in, you get shallow breathing. Sometimes you can hear the friction rub, as I mentioned, and the complications of this are pleural effusion and empyema, which we talked about in the infectious disease section. And then if you're breathing shallowly, this can also lead to atelectasis. So the key here is to treat the underlying cause, the infection, the pneumonia, whatever, and then also control the pain so that the person can breathe more deeply. So a pleural effusion is a collection of fluid in the pleural space. A small amount of fluid is always there. It enters through the capillaries and is reabsorbed through the lymphatic system, and it is what makes the pleura glide over each other during inspiration and expiration, and this reduces friction. When you have an excess of fluid produced or the fluid is inadequately reabsorbed, then you get a pleural effusion. This is always caused by another disorder. Usually it's transudative, which means that it seeps through by osmotic pressure. It occurs in non-inflammatory conditions such as in congestive heart failure, chronic liver failure, renal disease. Transudate is a very thin fluid. There's no protein. It goes from the cells into the interstitial spaces through a membrane, through diffusion. It's a passive process. And you see in the picture, the pleural effusion here is the fluid in between the pleural space, and you see the normal lung on the right there and the effusion on the left. An exudative pleural effusion, the fluid is thicker. It contains cells and other substances that are being discharged from the cells. Exudative pleural effusion occurs in an area that's inflamed. It's caused by the increased capillary permeability because of the inflammatory reaction. This happens with lung cancer, pulmonary emboli, pancreatic disease, and pulmonary infections such as pneumonia. This illustrates a normal lung versus a pleural effusion. You can see the pleural fluid has collected in the pleural space, and this particular picture suggests many different kinds of a pleural effusion. Transudative, we talked about, occurs with congestive heart failure. Exudative, we also talked about, occurs with pneumonia. Empyemic, we talk about in the infectious disease lecture in this section, and that's when the pleural fluid itself is infected. A hemothorax is a collection of blood in the pleural space, and a chylothorax, which is very rare, is a collection of lymph in the pleural space. The take home here is that you see the fluid restricts the lung movement, therefore the lung can't expand, the alveoli don't fill with air, and gas exchange does not take place. So the symptoms that you get depend on the amount of fluid. You may or may not have pain. Increasing dyspnea and tachypnea will happen because of the decreased space for lung expansion. And so if you don't have space for lung expansion, you don't get good oxygenation and you get dyspneic. You will have diminished lung sounds because of the diminished expansion, and you can also sometimes get a pleural friction rub. It's always diagnosed with a chest x-ray and sometimes a thoracentesis can either be diagnostic or it can be therapeutic. So treatment, bed rest, a therapeutic thoracentesis where they draw the fluid out, and you may see this in some of your patients at Kindred. It's a big needle that is inserted into the pleural space, and the fluid is just drained out into a sterile container outside. Sometimes they have to put a chest tube in. And sometimes, if it recurs, they do what they call pulmonary sclerosis, which is where they adhere the pleura to each other so that no more fluid can get into that space. Sarcoidosis is a lung disease that's characterized by granulomas. It causes fibrotic changes in the lung tissue over time. Nobody knows what causes it. It's an autoimmune sort of disease, and it affects other tissues in the body as well, most notably the eyes. It's, as I mentioned, a cellular immune response that is responsible for the tissue changes. And when you have fibrotic changes, we'll talk about pulmonary fibrosis next. Basically, that means that the lung tissue is destroyed and there's decreased area available for gas exchange. Pulmonary fibrosis is also called interstitial lung disease. There is an idiopathic kind called idiopathic pulmonary fibrosis, IPF. Nobody knows why it happens. There are other causes. There is a hereditary component. It's also more common in older people, exposure to certain viral illnesses, wood and metal dust exposure, radiation exposure, different medications, exposure to molds, birds. There is a smoking relationship with pulmonary fibrosis, and then some autoimmune diseases like lupus, RA, and then we talked about sarcoid also can cause pulmonary fibrosis. Finally, chronic GERD. If you get enough gastric contents in your lungs, it can also cause fibrotic changes. So what happens here is you get an injury to your alveoli. It causes chronic inflammation. These inflamed tissues are gradually replaced by fibrous tissue. The alveoli become very thick and scarred, and gas exchange becomes very difficult, if non-existent, and the lungs are very, very stiff. This is a good picture here showing the damaged, scarred alveoli. Pulmonary fibrosis is a progressive disease. The onset can be insidious, and then eventually you get dyspneic. With a chronic cough, you'll have crackles in your bases, severe fatigue, and because of the chronic lack of oxygen, you get clubbing. It's, as I mentioned, progressive, and it is a downhill course. There's no periods of stability with exacerbations as there is with COPD, but it just continues to get worse and worse. They diagnose it with a chest x-ray and a CT. PFTs are important. This helps you to measure the amount of oxygenation that is present and helps you to track the decline in oxygenation. They do blood tests for the autoimmune markers and the different diseases that we mentioned earlier. They can do a bronchoscopy and a biopsy to make sure that fibrosis is actually what's going on. Treatment, there are corticosteroids, there are new drugs that inhibit scarring, some new biologics that they use. Pulmonary rehab, very important to remain functional and keep up and keep moving. Eventually, they'll all need supplemental oxygen. Sometimes they will even do a lung transplant. Finally, we'll talk about occupational lung disorders. A lot of these things cause pulmonary fibrosis. Coal dust, dust from hemp, flax, cotton processing, exposure to silica in the air, all of these things can cause work-related lung disorders. Asbestos can cause a rare lung cancer called mesothelioma. And then there's asbestosis, which is pulmonary fibrosis caused by asbestos. And these are things that, now that we know more about them, the occupational health departments in these areas try their best to protect the workers using respirators to keep these particles from getting into their lungs.